So for the next session on pediatric neuroimmunology, I call Dr. Udani sir to please chair the session. Sir needs no introduction. I think we'll just begin the session with sir introducing our first speaker.
Professor Meng Lim is a very well-known name in the field of neuroimmunology. He works in the Evelina Hospital in London, and he's going to give us his first talk. Ming, please.
Thank you very much, and thank you for the organizers for inviting me. So today, I've been tasked to talk about biologics in pediatric neuroimmunology and how it's changing our landscape as to how managing conditions. Can I check it's moved on? Oh, yes, it has now. I'm going to give you an overview of biologics, a bit of history, as always, and then look at the huge sort of influence it's had in the management of particularly pediatric MS, but also in a lot of autoimmune, conditions. And of course, hint at what else we need to do to optimize, the management, and really to stress that it's the availability of treatment being there that has been enabled us to do things, but we also need a lot of, other things. So I asked myself actually when preparing this talk as to what exactly is a biologic. And this is what it is. It is actually treatments developed to target very specific pathways that cannot be delivered by small molecules, i.e. synthesized, molecules. So you have monoclonal antibodies, which is what we're most, sort of used to. And these are genetically sort of engineered in mouse often, and we'll tell you a little bit about that. They're fusion proteins, so this is very similar to the monoclonal, whereby you attach the whole sort of receptor you want to target to the Fc component. The technology is a little bit different. Recombinant proteins, and then obviously, cells, i.e. gene therapy, but more relevant is the CAR T, where the A component instead of antigenic is the autoantibody that's been engineered. We won't have time to discuss that. And then vaccines like your mRNA vaccine. Okay, so now this sort of historical sort of adage, and it's exceptionally relevant this year, and coincidentally, the review that helped actually prepare this presentation a lot better is the 50th anniversary of the key determinant of how we can make monoclonal antibodies, which, as you know, started sort of many years ago when Edward Jenner injected cowpox into a boy who then did not develop sort of smallpox, and hence, the autoimmunity and protection aspect. And many years later, it stuck. There was going to be a picture of Paul Ehrlich as we're waiting for it to come up, determining that the adaptive immune system was probably the target of treatment if you wanted to change or cure the outcome of autoimmunity. Does someone want to have a quick look to see why it stuck? And then the third image was going to be one of the key studies, and this was from a team, cool, McMaster, and how that actually tracked the formation of an agglutinin, both in the serum and in the lymph node of patients after they've been, or mice actually, after they've been inoculated with a bacteria. And this is the immunoglobulins, being produced. And this is really the technology. So the mouse gets the target antigen, produces a whole clone of B cells that are then selected and then fused with the myeloma cell so that you can produce lots and lots and lots of antibodies. And it's this hybridoma technique that was discovered or successfully done in 1975, hence the 50-year sort of anniversary of the production of monoclonals. And then since then, we've just gotten more refined from the murine form, which has got its name OMAB, to the chimeric form, which is essentially where the variable section has got a human, the variable section remains half mouse and half human, and the Fc segment human. So this is iximab, so there's rituximab, and then it's humanized. And as the technology allows for the transgenic mice to fully express the human Fc segment, it became a human version of that. It's essentially UMAP as opposed to the ZUMAP, which is like natalizumab, ocrelizumab, and then for the CD20s, ofatumumab. So there are many, many, many sort of monoclonals as such. And you can see here that to date, there's at least 200 monoclonals available. And as you can see there, neurology usage probably forms the smaller version of that, but not forgetting that a lot of the immune causes and autoimmune causes are borrowed to use in neurology as such. And the generation of these monoclonals have evolved that the humanized form or the human form are going to be mainstay as such. And the benefits of the sort of humanized form, as you know, is the reactivity to that. Okay, so where do you think it's going to be sort of most useful? Would certainly be where you actually know the primary sort of mechanism, and these are some monogenic disorders with CNS sort of autoimmune sequelae. And despite the large amounts of monogenic condition, the only condition that really has got the key targeted treatment is the CTLA4, as a lot of you will know, and that actually targets that with a fusion protein that I mentioned that little bit earlier. But I'm going to impress on you that despite the availability of monoclonals in a whole host of conditions, we need 4 key things still, and it's all clinically driven and it's totally relevant to you. One is to make an accurate and fast diagnosis. So if you take multiple sclerosis, for example, we know that the initial McDonald criteria was not really written for children, and it took us a while to be able to validate its use in children. And then the 2017 criteria was written with pediatric specificity because there were some pediatricians on the panel as such. And although it took us less time, what it really showed us was that we could make the diagnosis of MS at first presentation in about 90% of patients, twice more than you would do with the older criteria. But it's bearing in mind that the change in criteria has afforded us the ability to make the diagnosis faster at the expense of specificity. So that's why you've got to use that criteria very, very, very carefully. And of course, we brace ourselves now, and some of you may have heard of the 2024 criteria that will refine that little bit more. So moving on, the second component is that you need to have good access to treatment, and that could be provided in sort of units that see many, 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 many children. And this is an example of the London service, whereby over the years where we have implemented a specialist service, patients are seen faster, diagnosis is made better, and they have more access to treatments. Of course, carefully, access to treatment is also exceptionally tied in to the availability of the treatment as such. The way we think about disease is also different. We're starting to treat patients now based on imaging disease activity rather than relapses. And of course, the crucial bit is to start hard and not escalate only as patients sort of relapses. So this the induction oncological model as such. And then the fourth key component here is the availability of treatment, of course. So 3 randomized controlled trials in pediatric MS, those are not monoclonals. Those are small molecules, and 2 of the 4 here are monoclonals, of which ocrelizumab, the OPERATA-2 trial, we know has completed now, and the breaking news will be in ECTRIMS next week. So we wait with bated breath, but we know it's going to be effective because it's been effective in other conditions, in adults, etc. So in the UK, we're very lucky that all treatments that are approved in adults would be available to the post-pubertal child as defined by 12 rather than the pubertal status. But in many countries where that's not available, despite the good evidence, you are not going to be able to get the same level of improvement in patients. But what is the level that we're getting? And it's really the real world data that has helped us here. And this is just a personal sort of run through of the 3 epochs of my sort of life in managing these children. The first epoch being patients who were put on just interferons, and then escalating to more effective treatments as they become available. And if you can see on there, you can see the reds are the relapsing patients. And then the second epoch essentially is patients that were preferentially put on slightly more effective treatment. And you can see there that, it's improving, but there are still sort of relapses. And in the final epoch, because of availability of ocrelizumab in the UK for teenagers, of which virtually all our patients are on that, we had to cancel sort of relapse clinic. So the change in this sort of relapse, at least outcome in these patients, and many world sort of registries, international registries and national registries have contributed to this data in larger and sort of more robust data sets. So the American cohort, and what it's also showed is that this effect is sustained over a period of up to 5 years. The reason being all the randomized controlled trials are only over a sort of 2-year period. But of course, the key icing on the cake is really, is it going to change disease, accrual as such, or disability accrual? And we know from previous studies that if you look at any risk factors of disability, you only identify it 10 years later. So children are more sort of robust in terms of repairing. But of course, because you've had MS for a long time, you're going to get, disabled. So 9 or 10 years, and we're now having emerging sort of data to demonstrate that if you put patients on early immunotherapy, particularly the higher, active one, their disease accrual is significantly better. And there is a dose, effect of that as well in that paper. And ultimately, what we want to be able to afford these patients is a good and normal, a social economic outcome, as we know is adversely affected with any form of chronic disease compared to their peers, compared to their siblings, without the disease. Okay, so the 4, key factors, and this is an example of real-world data just to highlight that, rituximab has got good efficacy in addition to the evolving evidence of ocrelizumab, and this is essentially real-world, data. The effects of DMT in disease progression, and you can see here in larger sort of registry, really sort of allows you to highlight the 2 key factors, as I mentioned already, and this is the example of that paper, the early and the high effective, treatments, of which most of them are, monoclonals, but not exhaustively, of course. The role of biologics in autoimmune encephalitis I'm going to touch on because it's quite small and it's quite rituximab sort of centric, as such, because that's one of the tools that we use. So there's a general theme that we tend to be sort of 20 years behind oncology and maybe 5 years behind some of the adult MS, sort of world as such, although the gap is closing in. So first line immunotherapy, this is observational data. And if you look at panel C and panel D, and this is based on the MRS score that some of you will be familiar with. It's a categorical score where one end, that the red bit is not good, death, and then the whiter bit is a normal outcome. You can see from panel C to D are patients that have not improved, but in panel C not been given rituximab usually, or it could be cyclophosphamide, and in panel D they were given a biologic or cyclophosphamide, and an improvement in outcome. This was, confirmed in a retrospective meta-analysis in 1,500 patients where we could get individualized patient data. In addition to the first-line benefit, there was benefit in rituximab, both in relapse course and also in disability, if given early as such. And Russell's done work on the rituximab use, and we can infer its benefit in a whole range of sort of inflammatory, conditions as such. So with this, comes the armory that we have, and I'm just going to highlight to you only the B cell sort of depleting, agents as such. And that rituximab targets CD20, and it's actually the plasma cells more downstream that we would need to target if we want to be more specific for antibody production as well. But as we've learned from MS, which started life as a T cell sort of mediated disease, and now an anti-CD20 MIT mechanism being the primary effect that, or biologic, that has caused us, has caused a huge, benefit in treatment. I briefly touched on this in the pre-Congress talk that some of you were also here, that the immune system, it's quite complex. All have downstream effects and the effect of one cell on the other, but you could take a more targeted approach. And of those 200 monoclonals, there's at least 25 that will be applicable in the sort of B cell region. But remember, the blood-brain barrier is actually crucial in our decision making for two reasons. The FC receptor that actually internalizes antibodies, particularly on immune cells, are actually found on the blood-brain barrier to exude all the abluminal antibodies from inside to outside. So it gets rid of sort of antibodies. So that could be a target. And the second, of course, is that the blood-brain barrier is there to limit proteins as big as antibodies getting into the brain. So many monoclonals would not be, in the brain as such. So it works by depleting peripheral immune system that ultimately gets into the brain. And a good example of one that excludes them from getting into the brain, some of you will know, is natalizumab. It's an integrin 4 receptor, so it blocks the cell rolling of lymphocytes, getting into the brain. So the mechanism. So in the last section, what's in the future? And I just wanted to highlight two components of monoclonal production that has become used more frequently. The first is tagging a drug to the monoclonal, and this is widespread use in sort of cancer treatments now. So you target a specific cell that has that receptor, and you include a cytotoxic agent within that monoclonal to just selectively destroy that cell. And of course the second, and there's even allelic now, but the bispecifics to start off with. So your monoclonal will recognize two receptors, and you will have to only bind the two before it becomes active. And you can see here that there clearly is quite a complex thing, but this is the only way to sort of target cells that may have two receptors, or actually target cells that are exactly interacting with each other already. And my view is that certainly that to get things into the blood-brain barrier, we may have to do something like that. So I'm going to end on the global considerations in this audience, having been in the pre-Congress and heard a lot, about availability of treatment, and also sort of barriers, to diagnosis, as you can see there. And of course, we're sort of working in sort of countries where healthcare provision doesn't have to take into consideration your patients, coming back to treatment. So you can see here that, cladribine, which is an oral treatment given only once and then given a month later, that will then have a long sort of effect, or not lifelong, but 5-year effect, or rituximab that is given once every 6 months has huge, benefits in delivery of patients, by contrast to something that you give every day, where I'm told some of you would guarantee me that the patients that you're prescribing it to will stop taking it the minute they leave, hospital as such. So this is a sort of nice review. So I'm hoping that, I've summarized or convinced you that optimizing is more than just the biologics. We still have to rely on your core, clinical skills of early diagnosis. And then we really need to stress that once you make the diagnosis, early optimal rather than aggressive treatment will be the best mainstay for these patients, and actually preventing them from getting a disability rather than minimizing the disability will be the next key step for our patients. If you ask every patient from any condition, they don't want seizures at all, they don't want a 50% reduction. Similarly with disability, they do not want to be disabled at all. And this comes in understanding immunobiology. Thank you.
Thanks very much, Ming. Questions from the house? We have a few minutes.
Brilliant.
Terence?
He's speaking.
Yeah. No, I thought he was having a question too. I had a question about this how long do you give in different disorders? Is how long the duration of the therapies in different disorders? It's a bit arbitrary in the
Correct.
sense that disease activity sometimes may be difficult to
Yeah.
judge.
Yeah.
What's your comment on that?
Yeah, so I think it's a. I think you need to know which condition it is. So, for example, in NMO and aquaporin 4, disease, we know that unless we're going to have something as effective as we're on at have been on at the moment, it's essentially lifelong, as such, and we wouldn't advocate stopping because the risk of getting a life-threatening and even life event changing transverse myelitis would be too much of a risk to take. But nonetheless, some patients do opt to consider stopping, and some adult physicians, I've never had to do it in pediatrics, would offer the patient an opportunity provided they understood that risk, and you may use the antibody as a biomarker. But we do know fully well that in every condition, even if the biomarker becomes negative, it will be positive at relapse, and we've seen enough of that. With MOGAD, it's a developing field at the moment. Observationally, at least, patients do appear to stabilize after a period of time, and the consensus recommendation appears to consider de-escalating or considering stopping treatment after 2 to 5 years of disease stability. But that's an evolving field. In MS, as the treatments become more and more effective, as we approach the possibility of curative treatments, it will still be a significant lifelong, or at least modest burden for the patients until that happens. But the mindset is actually keeping the patient in as good health as possible to afford them the opportunity to get the curative treatment downstream. Because if you render the patient so disabled, then the risk of the treatment downstream, which is unlikely to be zero, is likely to be high, like bone marrow, would not fulfilled, or it would not offset the risk benefit sort of ratio. So in answer, majority of autoimmune conditions are not yet treatable, but there are some that naturally burn out, and we rely on those to stop treatment rather than effective treatments.
Thanks.
Can I just ask a question? Dr. Pratibha Singhi, we have been hearing you, and this is a brilliant talk. I still feel that we haven't had enough evidence to say, like you said, early optimal treatment, but not early aggressive treatment, and where to draw the line in which condition is still not very clear to most of us, right? So if it's an MDR, what would you say is an early optimal treatment, for example?
No, absolutely. And we were having this discussion that little bit earlier on as well. So if you take any condition like MOGAD, for example, where we know that maybe about 30% of patients will relapse, your intervention after the first episode will afford the 30% a chance of a relapse free episode, whereas the other 70% are not going to benefit from it because they were not going to relapse anyway, so you're putting the other 70% at risk. But of course, we heard today from Kevin that there are influences of the relapsing course, so we optimize the early treatment, 7 days, we optimize the longer treatment, and that will prevent that relapsing course as such. And currently we think that's the most effective. So you're right, it has to be data driven, but the data is only as robust as people publishing it. And I would urge countries like India and like China, where you house the biggest population of MOGAD, we need to derive that from that. The best European data set will not be powered enough to answer that question because of the heterogeneity of severity and response to treatment as such. So absolutely no robust data, but it is the logical data rather than evidence based.
Thank you for a lovely talk. Thanks. Now we have Terence Thomas from Singapore, who's going to speak on his experience in encephalitis.
Can we? Yeah. Hi. Good afternoon to everyone in the hall. And first off, I'd like to thank the organizers for inviting me to speak on this topic. I've really enjoyed the meeting so far. It's been high energy, a lot of great discussions, a lot of food for thought and learning. So today I've been asked to speak about the autoimmune basal ganglia disorders. And you've noticed I've crossed out auto, right? And if you heard from Russell Dale yesterday during the plenary, it's important to be careful about the words we use when we talk about disease, because it frames our understanding and drives our decision making, right? So essentially, we're going to speak today about the immune basal ganglia disorders. So we prepared a bit of a clinical focus talk, running through maybe adaptive immune disorders. I've included innate immune disorders, which is essentially acute necrotizing encephalopathy, because that's often going to be a question. Is this a kind of a basal ganglia disorder? And then important to consider the autoinflammatory disorders as well. And especially important to consider the mimics, right? In all our neuroimmune conditions, there's always the disclaimer, the last line, that we exclude competing differentials, right? And that's probably really important when you're considering basal ganglia disorders, because the range of mimics is quite broad, right? And the tools we will use in the next 15-20 minutes will be essentially clinical radiological pattern recognition, right? So it's trying to look at sort of biomarkers in the clinical presentation and radiology. Right. So first off, the clinical features, right, of a basal ganglia disorders, which could be immune or not, right? So essentially, in an immune disorder, we look for the presence of fever and often encephalopathy, and then the extrapyramidal syndrome is often characterized by things you can easily see, right? The positive signs like dystonia or chorea, right, or bolismus, which is just exaggerated chorea. Tremors, some posturing and rigidity, and in some conditions you have stereotypy and tics. But there's also negative sort of very clear signs that you need to take maybe a step back and observe, right, to pick this up, right, like bradykinesia or apathy or blunting of affect or behavioral sort of change. And then noticing the drop in tone. Is not always going to be increased tone. You could also get hypotonia, and then the effect on language, right? Comprehension, fluency, right? So these are important things to look for, right? And sometimes we also do see a collection of symptoms we call Parkinsonism, right? So the combination of bradykinesia, tremors, and a gait abnormality. In terms of imaging, I think the area we're looking for is really the basal ganglia would be the caudate and putamen, right? Less likely to be involved in immune disorders is the globus pallidus. The thalamus, I think that's where I think we most often if you're not careful with what the words we use, right? The thalamus is not really part of the basal ganglia, but it is related functionally. And sometimes you would also get the thalamic involvement, right? There'll be some changes in thalamus in addition to the basal ganglia itself, but maybe that helps our decision making and saying this is likely to be immune or not immune or mimic, right? So you may see thalamic lesions. That's probably clearer in, let's say, in A&E, right, where we see predominantly thalamic lesions. And if you see a combination of striatal and thalamic lesions, then that also directs you in a certain sort of direction in terms of what decisions you make. So the most maybe clear immune syndrome is what we call basal ganglia encephalitis, right? So in imaging, you would see mainly the caudate and putamen being involved for the stridum. It is almost always bilateral, right? And sometimes there's a little bit of edema in the external capsule or in the internal capsule, but is mainly affecting the stridum. It could be restricted diffusion as well on imaging, right? And the clinical syndrome would be fever, encephalopathy, and an extrapyramidal sort of disorder as I described earlier, right? In this case, I put to you a child, 4-year-old boy with a febrile encephalopathy with Parkinsonism, aphasia, CSF pleocytosis, and a common respiratory virus in the nasopharyngeal aspirate. So often the infection may be happening together with the neurological symptoms, or maybe a little bit earlier, so like a post-infectious syndrome. And common viruses are the influenza virus, adenovirus. I put mycoplasma there with a star because often there's this great debate about whether if you encounter antibodies of mycoplasma, is it an acute phase reactant versus actually presence of a disease, right? So mycoplasma infections, to be really sure, certain, because it's hard to pick it up on your CSF, right? Because it's almost always negative because it's an intracellular organism, so you wouldn't have positivity in your CSF. So you're going to rely on antibody testing. And to be sure that you actually have an ongoing or current mycoplasma infection, you have to do titers 2 weeks later and look for a 4-fold increase, right? So in terms of decision making, then information is not available to you that is this really an acute phase reactant or a active in mycoplasma infection producing a basal ganglia syndrome at that point in time. SARS-CoV-2, the COVID-19 virus, is also associated with basal ganglia encephalitis. And sometimes we had patients with RSV, right, common childhood virus that also produces this syndrome. Then looking out into other sort of differentials where the immune system may involve the basal ganglia. In this sense, having a combination with maybe thalamic lesions will be Morgad disease, and depending on whether you would term this Morgad ADEM or Morgad encephalitis, is I would call this probably encephalitis because it's predominantly a gray matter involvement, the cortical gray as well as a deep gray involvement. But the syndrome may be very similar, like encephalopathy with Parkinsonism, sometimes dystonia and tremor, and often seizures as well. And usually you look for a clear positive MOG antibody, like a 1 in 100. The management plan, at least the approach, is quite straightforward, right? So it's essentially neuroprotection, which is important for all our patients with encephalopathy. Ensure you have sort of good blood pressures, perfusing the brain. Some patients require mechanical ventilation. If there's other organ involvement, which sometimes happens, then you need to support that as well. And then manage seizures well. In these patients, often you need symptomatic management for tone or dystonia. Often I sort of take guidance from our movement disorder specialists. But common medications you could use are dopa agents, bensaxol or trihexafenadil or clonidine. And then often also looking at any treatable infections that can be treated. Often if the mycoplasma antibody is raised and elevated, you may want to use ciprofloxacin, which covers mycoplasma, even though you may believe that this is an acute phase reactant, because you wouldn't know any better at that point. In terms of immunotherapy, I tend to use just steroids or IVIG. If it's very severe, then plasma exchange, but I don't think you need to use biologics agents in this sort of set of disorders. So looking at mimics, how we try to consider whether we are dealing with a mimic or not, I think the imaging helps you to define that, right? So if you see thalamic lesions together with basal ganglia lesions, then yes, this could be maybe a more systemic immune basal ganglia disorder. If you have just caudate and putamen lesions, let's try them, then this could be basal ganglia encephalitis or a mimic, right? But the list of mimics are broad, so you really have to consider your mimics. And certainly if you have just globus pallidus lesions, this is likely not to be immune, right? It's got to be some genetic metabolic disorder. Okay, so I put out some slides on some mimics that you need to consider. So first off, viral encephalitis, which is commonly the flaviviruses that usually affect the basal ganglia. But these are region specific, right? So in Asia, maybe Japanese encephalitis virus and West Nile will be things we look for. In Australia, it would be Murray Valley encephalitis. If you work in North America, then it's a Powassan virus, right? But in every region, you have your local flaviviruses that you need to consider, neurotropic flaviviruses. Of course, herpes simplex and Epstein-Barr also would involve the deep gray matter. And then also looking for subacute or chronic meningitis in the cryptococcus. Right? In India, I think you commonly see the CNS tuberculosis, which will cause infarction in the basal ganglia, and also sort of intense sort of basal meningeal enhancement close to the basal ganglia. And then you also have to consider metabolic disorders, a treatable condition. I've just put a few out here. So a treatable condition is thiamine biotin deficiency. You have a lot of mitochondrial disorders like Lee encephalopathy that affects this area. In India, I think you would commonly see Wilson disease, which also produces lesions in the basal ganglia. And tumors, brain tumors and glioblastoma. I mean, this is probably not the best example because it's thalamic, but you also may get sort of tumors that involve the basal ganglia. So that's another consideration. Then there's toxins, right? Back when I was before Singapore, I was working in Sabah and Borneo, and occasionally we get families who maybe have not prepared cassava well to allow the cyanide to leach out, and then they would present with cyanide poisoning, right? So if they had CNS involvement, you would have lesions in the basal ganglia. Sometimes carbon monoxide poisoning or methanol. These are other sort of toxins to consider. And in patients with renal failure, if we have uremia and encephalopathy, you would also get changes in the basal ganglia. Okay, so I think in most sort of discussions on immune causes of basal ganglia, you would encounter, of course, lupus and neuropsychiatric lupus associated with antiphospholipid antibodies, right? But I don't think this is really that common. In this well-characterized series from the rheumatology team in SickKids in Toronto, and where all comers, so all patients with SLE are in their sort of research program, the incidence of extrapyramidal symptoms in neuropsychiatric SLE is only about 1%. And if you include mood, it maybe pushes it up to about 3%. So it's fairly uncommon to see this manifestation, although it's something that you would always read about and probably teach, right? When you teach medical students, we always tell them to always to look for lupus and SLE, but it is really not that common. If you did imaging in neuropsychiatric SLE, often the imaging is normal, unless you have antiphospholipid antibodies, and that may predispose to thrombotic events, and then you may get stroke, right? But if you have access to radionuclide imaging, you could demonstrate that there is hypermetabolism. So it's different from how you use it in epilepsy, where you look for hypometabolism, but in terms of neuroimmune, if you're going to use PET scan, you should think like how the rheumatologists think. So we're going to look for hypermetabolism or hypoperfusion in SPECT. So just one slide on acute necrotizing encephalopathy, which is not exactly a basal ganglia immune disorder. It's more thalamic, right? But by most patients, you would see sometimes maybe the posterior putamen being involved, right? But if you do see caudate or putamen involvement, you may start to think about genetic A&E, right? So usually the presentation would be with fever and an illness producing a rapid onset of encephalopathy and neurological signs and symptoms. We did CSF, there would be no pleocytosis. And also you look for sort of presence of other organ involvement like shock and low platelets, liver failure, coagulopathy, right? And in E&E, remember that it's not only the thalamus, you also get lesions in the cerebral and cerebellar white matter and in the pons as well. So I'm going to, the next area would be the auto-inflammatory disorders, so type 1 interferonopathy. And this is a group of disorders that involve our sense of self and picking up like DNA debris, and whether these are like recognizing sort of self DNA versus foreign DNA, and sort of genetic mutations in this system can then produce a chronic sort of inflammatory state that often involves the basal ganglia and white matter, right? So often the symptoms are subacute or chronic neurological symptoms, together with MRI showing leukodystrophy and calcification, and also skin involvement and other sort of organ involvement. The lesions you would see in the basal ganglia is mainly calcification, and if you did MRI, you would also see a leukodystrophy. Okay, so the last conditions, if you allow me, just is to speak on the sydenham chorea, which is essentially a disorder of dysregulated immune reaction to a streptococcal infection, producing chorea, tone abnormalities, and often a behavioral syndrome as well. If you have on imaging, often we expect normal MRIs, but if you did a PET, you would also again see hypermetabolism in the caudate and putamen. Right? So last few slides, we're just going to put out a plug for our consensus guidelines that we just produced on sydenham chorea. And this is, we're just waiting for proofs, and it should be available online. And it is a sort of multinational and international collaboration amongst many of you, some of you in the hall here, and Shefali Gulati from India, and Suvashini Sharma, who's now in Toronto, but she represented India in our effort. We essentially tried to sort of put out recommendations for evaluation and assessments of patients with sydenham chorea. And this includes access to therapy and educational assessments. It also includes interventions for behavior and treatments for behavior, and statements about best treatments, antibiotics, and immunotherapy, and treatment for symptomatic movement disorder. So I put to you today the idea that we need to have good clinical and imaging pattern recognition in the immune basal ganglia disorders, and also to carefully look for your mimics when you assess patients. And again, the same idea that we've been putting to you throughout the conference: always treat early, and maybe just standard sort of steroids and IVIG, but maybe without using biologics in this group of patients. Thank you very much, and this is my team from Singapore.
Thank you so much, Terence. Not sure we have time for but any one burning question if anybody has. Yes.
What is special about the globus pallidus which protects it from immune attack?
Sorry, meaning why is it special that it's
Why
not
doesn't it get attacked in the immune-mediated injuries?
Okay, I wouldn't really know the answer to it, but it's something that we observe, that the globus pallidus is often not involved in the immune disorders. It's just maybe it's our pattern recognition rather than out of knowledge of why it may or may not be involved.
Thank you.
Thank you. Thank you, Terence.
Thank you.
I think the last speaker, Naveen, is going to give us emerging horizons in pediatric neuromuscular autoimmunity. He's from PGI Chandigarh.
Good afternoon, everyone. It's a great honor to come here and speak to you on this topic. I'm filling in for Dr. Rohit, who could not be here, and I took the liberty of curtailing the topic because it was too wide to compress into a 10-15 minute session. So I'll be talking particularly on GBS, and part of the understanding of GBS as as new treatments emerge would also have an implication on other disorders of peripheral nervous system. So I'll discuss some emerging diagnostic, pathophysiological, and therapeutic advances. And I do this by reviewing some selected studies which I believe have really impacted our understanding of this disease. So starting with the diagnostic process, we are very familiar that we rely on electrophysiology for the firm diagnosis, and most of the other tests like lumbar puncture is primarily for excluding competing diagnosis. Anti-ganglioside antibodies, I'll have a few slides on that, but that again have not really helped in the diagnostic process. So nerve ultrasound has lately come up. Even 70 MRI has been evaluated as a diagnostic modality, but again it's in the realm of research. But nerve ultrasound in the right hands and with the right expertise has been found to show swelling of the nerves, which can be focal, as you would expect in patients with particularly demyelinating polyneuropathy. And because of the acute nerve edema, experienced examiner can pick up these changes as early as 1 to 3 days from onset. And it seems to affect both the proximal as well as distal segments of the nerves. You can also pick up the root swelling. So here's the image. In A, you can see the median nerve distally, which is swollen, whereas in the image C, it is the same patient with median nerve above the elbow, which is not so swollen. So you can see that focality of involvement, which is the hallmark of early AIDP. Then the other candidate, which is really come up at least to the clinical level, where it may feature into some of the prognostic algorithms, is the neurofilament light chain. And data from the SID-GBS trial, which was a sentinel trial which looked at second dose of IVIG in severely affected GBS in the European group. And so 293 patients among those recruited for this trial, they had serum NFL detected at baseline 1, 2, 4, and 12 weeks, and also CSF detection at the first CSF examination at baseline. And what they found was interesting, and what they found was that the higher NFL levels at entry week 1, week 2, and CSF NFL were associated with the severity of the disease, that is inability to walk, at 4 and 26 weeks. And they used this NFL data and fit into the model of prediction of severity. And what they found was that it improved the prediction ability of the model itself. So this would be relevant for future studies where you want to randomize, where you want to categorize patients when they come into the hospital to various therapies based on their severity, based on their prognostic model as to who is going to benefit from more intensive therapy early on. So this certainly seems to have some potential there. Then a very simple marker which all of us do, we never pay attention, but there is an interesting study on albumin and correlating it with outcomes in GBS. And this is primarily in adults, but who knows, we may have a similar study in children as well. We have to look at our data carefully. So here they found that serum albumin, not at baseline, but at 2 weeks after treatment, correlated with clinical severity, independent of other clinical diagnostic and prognostic factors. So, and this was not just those who had, hypoalbuminemia in the, in the defined range below 2.5, but also low albumin within the normal range as well. So coming to the anti-ganglioside antibodies, which have been, detected long time back, and but the problem is that we rarely use this as a diagnostic or a prognostic tool, except sometimes when we are confused in patients with Miller-Fisher, where you will get a GQ1B and hope it comes positive. My experience at least tells that it's not positive even in MFS very frequently, particularly if it has an overlap with GBS. So here we look at this study published in 2025 in routine clinical care settings. We see that the positivity rate is very low, and mainly it comes positive in AMAN and MFS variants. and there is a lot of cross reactivity. The same patient may test positive for more than one antibody as well. And in a very small study that we did on prospectively enrolled children, 83 children with GBS who had all variants of GBS, we found the overall positivity to be just 7.2%. I mean, it was 20% among the Aman group, but the positivity really does not encourage us. But the IGOS International Consortium, or rather I would say the research group which collects all the data on all ages of GBS, their biobank samples were assessed, and these were close to 1,400 individuals. And using the combi a very specific assay, they looked at not only the glycolipid antibodies but also at complexes. So much of the reason that has been attributed is that there are no single glycolipid antibodies. There are probably antibody antigen complexes circulating, or the antibody levels are low, or they are not being detected by the usual assays that we are using. That is the reason why we are not detecting these antibodies. So maybe we'll have better assays in the future which will detect these antibodies. At least this study really encourages us to look for antibodies using different methods. So a word about why these antibodies are important, and this is a fairly old article, but this was GBS was the first human model and animal model to prove molecular mimicry in an autoimmune disease in human beings. And you can see in the picture how the GM1, the structure of the GM1 ganglioside, and the below is the structure from the Campylobacter. It is absolutely having the same structure, and that is why there is a cross reactivity and identification of this as an antigen when the blood nerve barrier is disrupted. So the traditional model of autoimmunity in GBS was that this is the axonal GBS, in which you have antibody produced due to the exposure to the bacterium, and this antibody then crosses the blood nerve barrier, and then it binds to the antigen on the nerve and then recruits the complements, and then there is recruitment of the macrophages, and that initiates the damage to the axon. And this is a beautiful electron microscope really showing that you can see A is the axon and M is the macrophage, which has really inside the sarcolemma and the myelin sheath, damaging the axon itself. And we know that the GM1 is concentrated around the nodes of Ranvier, and this is where the majority of the damage occurs in the Aman variant or the axonal variant. However, this is one of the very recent works which really emphasizes the role of T cells in targeting peripheral nerves in GBS, and this is a very landmark work from the Switzerland University of Zurich. And what they showed is that cytotoxic peripheral nervous system myelin reactive CD4 T cells are infiltrating into the peripheral nerves in patients with GBS, and they contribute to pathophysiology after their synthesis is triggered by various viral agents. So we do have T cell mediated autoimmunity as well. So after reading this work, I went back to this Lancet publication, more than 20 years old, where they had postulated that in patients with demyelinating phenotypes, while the B cell antibody may be active, but it is not detectable due to the reasons I said, but there may be a T cell mediated pathway, which again, downstream recruits macrophages and causes damage due to recruitment of not only macrophages, but also downstream the complement pathways. So again, a electron microscope showing the tongue-like macrophage extensions which are splitting the myelin sheaths in patients with AIDP. You can see this black arrow where this is the tongue process of the macrophage really stripping off the myelin of the nerve. So in essence, the model of GBS, which was very simplistic initially as to antibody-mediated myelin injury, has shifted to two phases now. The AIDP and the Aman MFS have distinct pathophysiologies, whereas the B cell mediated antibody production along with T cell may be the major pathophysiological basis for AIDP, but in Aman it may be more T-cell initiated autoimmunity. The interrupted arrows showed mechanisms which we don't understand as well as of now, but are postulated. So this increased understanding of these pathways, not now, but when they were postulated more than 20 years ago, have helped us, design new therapies and test new therapies, and I'll come to that in a minute. So you need to remember this diagram, and I'll be talking on what drugs are really in the pipeline based on the pathophysiology here. So you can see that look at one where the antibody is really binding to the, this is the portion where antibody is binding to the antigen, and the early complement gets activated, and through the series of steps, finally the C5b gets activated, and it then results in damage by recruiting not only other immune cells but also direct damage through membrane attack complex. So remember the 1, which is the antibody binding. Remember the 2, the C1q, which then goes on to the downstream, and remember the C5, the conversion of C5 to C5b. So these are the 3 steps you need to remember, because we have now targeted therapies for all these 3 steps. So coming first to the downstream, that is the last step, C5b, and you have the eculizumab, which blocks the conversion of C5 to C5b. And this was initially thought of as a therapy in GBS, and in a randomized, phase 1 trial, 28 subjects were out of which 8 were randomized and 5 received eculizumab. They said it is well tolerated and safe, and then eculizumab was tested again in another trial, findings of which were published in 2024. Here you had IVIG with add-on eculizumab versus placebo tested, and they had very robust outcome measures, but unfortunately on all parameters this trial failed to show any benefit of eculizumab. And possibly you can understand, because it's more downstream, so you need to go maybe a little proximal in the immune pathway to really impact the outcomes. So here again, in 57 participants, none of the key primary or secondary outcome parameters reached any significance. Then we come to the C1q inhibitor, which was the second step in the diagram I showed. This was known as ANX005, recently named as tanruprubart. And this was initially tested in 50 patients, found to be well tolerated, and showed effective C1q inhibition and reduction in the surrogate marker of NFL, and then went on for a phase 3 multicenter study, which the design was, I don't know, I am not a little comfortable with the design. It was no IVIG plex or placebo versus AXN. So it was virtually no treatment versus AXN. So the patients in the control arm were not receiving either IVIG or plex, but the primary endpoint was met, and there was a 2.4-fold higher likelihood of being better in the state of health than placebo at week 8. So, I mean, essentially it's a proof of concept that this drug does work, and this drug may soon receive FDA approval for this indication. And this is possibly the first drug we are seeing in, last several decades as a specific, therapy for GBS. Then another promising agent is in imlifidase, and this is basically an enzyme which is secreted by Streptococcus pyogenes, and it specifically targets and cleaves IgG antibodies, and it acts right at the first step when the antibody is about to bind to the receptor. So this is in phase 2 right now, and we have a trial which is recruiting, and we would know whether this really holds promise or not. And finally, the efgartigimod, and this again acts at the very first step where the immunoglobulins are binding to the Fc receptor, and it prevents the competitive inhibition of binding and also enhances the IgG degradation. So 2 mechanisms primarily, and it is being evaluated in phase 2 clinical trial for host of indications. It has hematological indications. It has recently also been approved as a new treatment for CIDP in adults. So it does hold promise. but we have to wait and see whether it really works in GBS. So where are we right now in terms of, I mean, while these drugs look exciting and at least some of them will reach the phase of clinical use, where are we right now? So we know that 40% of predominantly adults will have no clinical improvement. In kids, this number may be a little lower, maybe 20%. So what do? We give combination therapy, or we repeat IVIG, or we follow up Plex with IVIG. What is the evidence? So this, again, a lot of you must be familiar with this trial. This is the GBS trial. Again, a large group of patients in Europe recruited after the initial IVIG to receive a second IVIG dose. So here again, this trial was negative, showing that second IVIG does not help patients who do not respond after first IVIG. So, and the group that received second IVIG fared worse in terms of serious adverse events. So, if you look at the current European Academy of Neurology guidelines for GBS, there are two phases, the first 2 weeks and the 2 to 4 weeks. If the patient is non-ambulant, Plex IVIG equally effective. If the patient comes within 2 weeks and he is still able to walk, you could use 2 Plex exchanges or IVIG. Whereas if the patient comes late and he's still ambulant, that is after 2 weeks, and he's either static or improving, you don't need to really give any intervention. So that is the main difference in how you approach them in the first 4 weeks. Now the question comes as to those who do not respond. So if they don't respond to the first dose of IVIG, there is no evidence to support the use of either Plex after IVIG or to use the second dose of IVIG. So switching of immune therapy or using the same immune therapy again has not been proven to be useful as of now. But there is a small subgroup, and that is the patients who initially improve and then have a secondary deterioration, or they have a fluctuation in their symptoms. There you can consider repeat courses of IVIG as well as further Plex. So that is the subgroup you need to remember. So this is my final slide, and it's not only drugs, it's also that it is like time is brain, time is also nerve. And this is an interesting study which looked at patients from 2 Korean centers, and what this saw was, does early IVIG really impact the prognosis? And what they found was that early initiation of IVIG affected outcome, degree of improvement, as well as the speed of recovery. So it's not just the intervention, it is also the speed at which you really approach these patients which really matter in terms of prognosis. So the key points from my presentation are that we are looking at some of the new diagnostic modalities which in the good hands can be really useful at bedside. We are looking at markers as simple as albumin and NFL, which may fit into the prognostic algorithms. We have newer understanding based on the role of T cells, and you have drugs in the advanced stage of development which may change the prognosis, particularly for severely affected patients with GBS. And we also have better understanding of how to use IVIG and Plex in unresponsive GBS. So with that, I'll end my talk. Thank you.
Thank you, Naveen. Thank you for that update. One question from anybody? Yes. Can you give a mic, please?
What is your comment on use of steroids in GBS? And
So,
nowadays it is various centers are started using and various studies are underway.
Yeah, I anticipated this would be the question, sir. So I'm afraid we are not giving steroids their due, and we are not really testing them in large group of patients. I mean, we have just disregarded them based on our experience in AIDP. So I think there is a scope of testing steroids, particularly the right steroid in the right dose, in at least the subgroup which has AMAN and which has predominantly T cell. So there is a merit in, but then we'll have to come together and design a trial and prove that they are useful. As of today, I'll say that steroids are not recommended because whatever limited data we have, it seems to worsen the prognosis. But I agree that they probably have not been tested thoroughly.
I think one more question. I think that's it. No, that gentleman over there, please.
Yeah, when we think of in Gulenberry, we think of IVIG or Plex. And when you think of when to think of combining both, we wait for, say, if we have started with the IVIG, maybe we have to wait for Plex for 2 weeks. But but there was a query whether we can combine both or not after
Yes.
5 days.
Okay, so that's what I said, that there is no evidence to suggest that the combination is better than either of them being used alone. So as of now, there is nothing to suggest that it is better.
Okay, my second question is whether there is a role of this neurophysin CSR antibody, autoantibodies in Guillain-Barré.
No, not in Guillain-Barré. Not in Guillain-Barré.
I think we are past time. Let's close the session. Thank you very much for this. Very interesting.